listen-only mode.
Hello everybody, thank you so much for joining us for today's webinar on prioritization. This webinar will be recorded and all materials will be sent out by the close of business day tomorrow. We're aware that some of you may have found out about this webinar yesterday, and we thank you very much for making the time to attend. So I just, oh, it's going to be one of those days. Okay, so these are the staff members who will be presenting today. I want to give a shout out to Caitlin Bayer, our COC Programs Coordinator. She's managing all the tech. So thanks, Caitlin. And then we have most of the COC funded projects in the balance of state are on the call, and you all represent transitional housing, rapid rehousing, and permanent supportive housing projects. So we have you from all over the state, so thank you for joining us today. I wanted to give a quick overview on these webinars. We have 3 of them. Today is the first one. They are all mandatory. Today what we'll really be focusing on is educating you about prioritization and the use of the common assessment tool, so really giving you kind of the foundation and the framework to what we're asking you. The next webinar on June 1st will discuss the prioritization standards for permanent supportive housing, rapid rehousing, and transitional housing. And we'll also discuss the homework, which we'll be giving you at the end of this webinar. And then on June 29th, we'll have part 3 of this series, and this will be an opportunity for us to answer any last-minute questions you may have. Kind of think of them as office hours. We'll be on the call and we'll be there to assist you guys in the final days before we have to go live with this. A quick overview of what we'll be covering today. So we'll be talking about federal policy changes over the course of the last almost 30 years. We'll be talking about written standards and also prioritization and common assessment tools. So 2 requirements that we will have of you guys starting July 1st. And now I'm going to hand it over to our wonderful Texas Balance of State Continuum of Care Director, Cameron Fowler.
Good morning, everyone. Thank you all for joining us today. I think I would be remiss at this point to not acknowledge some pretty significant news we all received last week. I'm sure all of you are aware, and some of you were impacted by really devastating cuts to our Tier 2 projects, and not only ours, but many projects across the nation this last week. I think we're still in a bit of shock around here, as I'm sure many of you are. And just want you all to know, we are with all of you, and part of this work that we're talking about today is to ensure that we continue as a continuum to be as competitive as possible, and to ensure that we are following HUD priorities and that we maintain our existing funding and get more. So for those of you that were impacted, I think this was mentioned in my reminder to some folks who hadn't registered. If I haven't spoken to you or your project personally, I will be doing that this week. And if you have questions about how the VI SPDAT will impact your project, if you are going to be closing your doors, please email me individually with those questions, and I'll be happy to work through those with you. This is going to be, this common assessment is just a piece of coordinated entry, and it's a process. And it's a process that we're going to need to work on individually with each of your communities. We feel strongly that taking this step with our grantees as leaders in our communities, and of course as those who are required to participate in CE, this makes sense. I know the timeline may seem a little quick to some of you, however, it doesn't feel that way to us. We've known about this for quite some time, and again, we're feeling the pressure from HUD really to move forward on this. So obviously our plans for these webinars happened before last week, but we do feel a little bit more of a sense of urgency moving forward. We also believe that this systems change needs to happen. It works. It's based on data. It's working in other communities all across the country. And I'm being recorded. Probably shouldn't say this, but I'm gonna. We really do feel like HUD has gotten this right. It is working. It's going to be challenging, but it does take away a lot of the hard decisions and work that you all are having to do and your intake staff is having to do at project intake. So Sophia is going to get into details about all of the potential challenges and the benefits. We're really excited to move forward in this work with all of you. Again, I'm not going to get into the details, but you're hearing us talk about data. That is what this is all about. Data and prioritization, focusing on the most vulnerable, and working to help you all to be the most effective project that you can be, and to make sure you're meeting HUD regs and requirements. And like I said, again, we really do feel like HUD has gotten this one right. I, prior to coming to THN, was able to lay the groundwork and start this process in Austin, and in a very short time saw how impactful this process can be, and how, despite lots of reservations, every project that was involved with the system there recognized very quickly the benefits of the system. This is where we're moving as a COC, looking at system-wide performance measures, so really all working together. And we are here to support you all in this change. We recognize it's definitely going to feel like more work at the beginning. We're well aware of that, and we feel like it's worth it. We also know, as a CE system, these are going to have to be tweaked as we go, but we've got to get started. This common assessment tool is where we need to start, and we're here to work with you all. We are moving forward as a continuum with the systems change, and I know that you all are going to take this and run with it, and I know you're also going to have some great questions, so we're looking forward to hearing those. Again, Sophia is going to really get into the nitty-gritty with you all, and we've got a limited amount of time, so I am going to hand it over to her. But I just want to thank you all in advance for your questions, considerations, and participation. I know it wasn't really optional, but we recognize still that your time is precious, and that these changes are, any change is challenging for a project to make. We know how hard you all work. We've been out in the field. We know that any change to a project is significant, and I just want to make sure you all know that we do recognize that, and we are thinking about all of those things as we're doing this work with you all. So without further ado, I will hand it over to Sophia to talk to you all about the details.
Thank you, ma'am. So this slide shows the major policies in homeless services in the last approximately 30 years. We started with McKinney-Vento. It was the first significant federal legislative response to homelessness. And what it did is it established 15 programs on the spectrum of services to individuals experiencing homelessness, and it also established the United States Interagency Council on Homelessness. In 2009, we saw the HEART Act, which was the reauthorization, there we go, of the McKinney-Vento Act. In 2009, President Obama signed it, and what it does is it includes substantial changes to McKinney-Vento, which include a consolidation of HUD's competitive grant programs, which is what we do every year with the NOFA, the creation of the Rural Housing Stability Assistance Program, which unfortunately they do not fund, the change in HUD's definition of homelessness and chronic homelessness, which they actually just changed again, the chronic homeless definition, a simplified match requirement, an increase in prevention resources, as well as an increase on the emphasis in performance, which Cameron mentioned a little bit ago. In 2010, after, I don't know, how many years? I So in 2010, after several years, my math is terrible, of McKinney-Vento, the United States came out with the first strategic plan to prevent and end homelessness. And what that did was establish several goals. The first of which is to prevent and end homelessness among veterans in 2015, which while that date has passed, we're still working furiously to accomplish that. Finish the job of ending chronic homelessness in 2017, prevent and end homelessness for families with children and youth in 2020, and set a path to ending all types of homelessness, which includes, as one of its subcategories, the development of a coordinated entry system to link families and individuals with the most appropriate assistance they need to prevent and end homelessness. And then in 2011 and 2012, you'll notice that we've seen a lot of stuff come out in the last 6 years. The ESG and the COC Interim Rules were released. The ESG Interim Rule revised the name for Emergency Shelter Program to Emergency Solutions Grant. And the change in the program name reflects the change in the program's focus from addressing the needs of homeless people in emergency or transitional shelters to assisting people to quickly regain stability and permanent housing after experiencing a housing crisis and/or homelessness. It also requires that recipients of ESG funding participate in a local coordinated entry system. And then the COC Interim Rule focuses on regulatory implementations of the new Continuum of Care program, which was, as I mentioned before, reauthorized with the HEARTH Act. This rule establishes the regulations for the Continuum of Care program, and through the establishment of such regulations, the funding made available for the Continuum of Care program in the statute can be more quickly dispersed, be consistent with the HEARTH Act requirements and system performance measures, and avoid any disruption in the current Continuum of Care activities. At least that was their goal. It also requires that a Continuum of Care develop a coordinated entry system in its jurisdiction, and it requires that Continuum of Care funded projects participate. And then lastly, we have the update to Opening Doors, which was released last year. And it's really just an amended version, and it reflects what we've learned over the course of the last 5 years. So there's a lot of data and best practices involved in it. And if you haven't taken the time to read these documents, I realize everybody has very limited time. However, I highly encourage you to read them. They outline HUD's priorities and expectations for continuums of care, so us, as well as Continuum of Care and ESG funded projects. So they're very important documents in what we do. And so what we've seen is an evolution in the federal response to homelessness. So these, so as research has increased and improved, our understanding of homelessness has evolved as well, and HUD has really been showing that through what they've released as well as what they're requiring on a local level. So these are, I think, really great expectations of kind of these are really great examples of kind of the thought that has changed over time. So what we saw a lot in the 1980s and the 1990s was the face of homelessness was really thought to be the single adult male with histories of mental health and drug and alcohol abuse. And I think what we have definitely found, especially since the recession in particular, is that there are a variety of subpopulations that need similar but also tailored interventions. What we have also seen in the 1980s and 1990s is kind of this more linear thought to housing. So a client has to kind of graduate from emergency shelter to transitional and then to permanent housing. They need to address mental health crises. They need to address any drug or alcohol abuse issues. And what we have really seen, especially I think in the last 5 to 10 years, is that that's no longer the norm. The norm is now housing first, where regardless of what circumstances people are in, we are putting them directly into housing because housing is truly the only thing that ends homelessness. And then lastly is kind of this lack of incentives for coordination between agencies both on a federal and a local level. And I really appreciate, I think at least in the last 5 years, that HUD has really been walking the walk. They have really been pulling in a lot of different departments because, as we all know, homelessness is not just a housing service system issue. It's an every system issue. It's a healthcare issue. It's a labor issue. It is every issue area touches homelessness in some way. So what they have really been doing through opening doors, through the ESG and COC Intern Rules, through the Hearth Act, is really incentivizing coordination and emphasizing kind of this hybrid coordination, because I think it could be argued in a lot of the smaller communities that coordination does happen, but HUD wants it to happen on a much larger data-informed scale. So the COC Intern Rule mandated that continuums of care develop written standards that lay out eligibility and prioritization criteria for transitional housing, rapid rehousing, and permanent supportive housing programs. This allows us to establish expectations on the operations of projects within the Texas Balance of State COC, ensures the projects and local housing crisis response systems are transparent to users and to operators, and establish a minimum set of standards and expectations in terms of the quality expected of projects. This also allows us, the COC, to codify best practices such as prioritization and the use of a common assessment tool into project operations. These standards will be crucial in developing a housing crisis response system in each of your communities, with a standardized coordinated entry process designed to serve and house the most vulnerable households first. We will have them completed and approved by our COC board by July 1st, hence these webinars. We wanted to start the process early to get you guys in line with what our written standards would require. We didn't want to implement them and say, now we have to do it. We really wanted to give you guys time to learn the theories behind it, to try it in practice, and to iron out all of the issues that may present themselves prior to July 1st. So, prioritization, one of my favorite topics. Sometimes people think of prioritization as favoritism. Prioritization is not favoritism. Favoritism is the practice of giving unfair preferential treatment to one person or a group of people at the expense of another. Prioritization is choosing someone for services based on the result of an objective tool. In the context of the VI SPDAT and the FBI SPDAT, which we will cover in depth in a little bit, we are prioritizing people for services based on their vulnerability or acuity, or in other words, their likelihood of dying on the streets. We have limited resources. Interventions are not one size fits all. Intervention should not be awarded on a first-come, first-served basis or the quality of a case manager. While this may have been the easiest way to address homelessness, it isn't the most effective, and it prevented communities from making inroads towards ending homelessness outright. This first-come, first-served system inevitably crowds people out, as we have seen. In contrast to this first-come, first-served approach, communities should draw upon by-name data, which will be generated by your common assessment tool, in order to prioritize people for the housing option that best fits their need. And those that are the most likely to end their homelessness permanently. So why? Why prioritization? There's a lot of reasons. The first is the data. So the data shows us that most people experience homelessness, only experience it once and for a very short period of time. Notable homeless researcher Dennis Kuhlhain from, I think, Penn State states that approximately 75% of homeless population is experiencing short-term episodic homelessness, and about 25% experience long-term homelessness, such as chronic homelessness. Most people end their own homelessness and don't need assistance or resources to accomplish this. Or I should say a lot of people end their own homelessness. If services as specialized as street outreach or permanent supportive housing are reaching people that don't actually need the help, then desperately needed services are withheld from the people that actually do need it. Again, limited resource allocation. So in a perfect world, there would be enough housing interventions, affordable housing, and supportive services to ensure that no one has to experience homelessness. But what do you do when there are not enough resources to achieve that vision? At the local level, this is all too familiar. You guys see it every day. I've seen it when I go to your communities. Every day you're having to make decisions about who to serve when there simply isn't enough beds or resources to serve everybody. The demand outweighs the supply outright. Every city in this country knows this and experiences this. The most important thing that communities can do to maximize their resources is to ensure that all homelessness assistance is prioritized for homeless households with the highest needs. I thought I switched forward. The reality is that some people are going to have to wait. There are more people experiencing homelessness than there are resources to end it. And before prioritization, the most in need or the most vulnerable were almost always the ones who had to wait. The most vulnerable are the most likely to die on the street. People living on the street have a life expectancy of 50 years. Was the average life expectancy 115 years ago. A study released a few weeks ago from the University of California, San Francisco stated that homeless individuals experience geriatric conditions decades earlier than their house counterparts. Although the people in the study had a median age of just 58 years old, they had more trouble bathing, dressing, and eating than 80-year-olds who had housing. By prioritizing resources, we can help extend people's lives. Money. It costs communities a lot of money to keep people on the streets, to manage homelessness. It is estimated that it costs $40,000 per year per person on the streets. This includes emergency room visits, jail stays, and detox facilities. For some people with the highest acuity living on the streets, the cost is considerably more. It also, so focusing on prioritization, especially for more vulnerable populations, excuse me guys, really I think we'll create a model for how we serve all populations, subpopulations of people, but also different kind of criteria of individuals experiencing homelessness or at risk of homelessness. If we get good at housing the hardest to serve, then it will be even easier to house people with less acuity. Providing services to people can be difficult, and successful programming with people with the most needs helps us realize the goal of ending homelessness can be achieved. And then I think probably one of the most important reasons, I mean all of them are important, but I think this one is particularly important. Communities across the country have done it. So in 2009, when the 100,000 Homes campaign started, they started with this novel idea of let's assess everybody with a common assessment tool, put them on a list, put a photograph to their client point ID number, and let's house the person most likely to die on the streets, the person with the highest vulnerability index score. And communities after communities after communities have ended homelessness for the people that are hardest to serve. When 100,000 Homes campaign ended, they had served 105,000 people. And I think this is also why HUD has continued with community solutions and has allowed them to continue with 0 to 2016, because the techniques work. People have employed these techniques and have ended homelessness in their communities. And lastly, and I really hate to have to put this on here, I really hate that this has to be a reason that I talk about, is that HUD requires it. There's so many other better ways to appeal to everybody about why this is worthwhile and it needs to be done as soon as possible. However, the fact that your funding is tied to it is both a huge carrot and a huge stick. And unfortunately, if you want to receive HUD funding, you have to do this. And I really hate that it infuriates me that I have to say this. I've gone on a lot of tangents about this the last few days. Okay, so So prioritization, it's done. Homeless services is not the only place that this happens. It happens in the healthcare field. So let's think for a moment about how emergency rooms function. Mary Dodson, who's in the room with us right now, loves this analogy. As with our housing crisis response systems, emergency rooms tend to have limited resources. So they have limited staff, they have limited bed space, they have limited resources. So therefore, patients are triaged based on the severity of their needs and treated for those unique needs. So serious accidents or injuries are prioritized over a broken ankle or arm. While it may not appear fair when you're clenching your broken arm in pain in the ER for 12 hours, you'll live. And ultimately, it's an effective use of limited resources, and the ER is focusing on saving lives for people that are close to death. So how does this analogy apply to the housing crisis response system? So let's imagine two people within the same community have been identified as homeless. One is a 65-year-old individual with a history of heart trouble and diabetes who has been living under an interstate overpass for the last 20 years. The other, a healthy 25-year-old, was recently laid off from his construction job and has been rotating between a friend's sofa and a local shelter for several weeks. It's clear that both individuals need help. It's very clear, but it would make little sense to provide them both with the same kind of assistance. While the 65-year-old may need permanent housing and support services, short-term rental assistance may be all that is needed to help the 25-year-old get back on his feet. So providing people with the right assistance at the right time is key. What we are working toward is building an effective data-informed housing crisis response system which makes homelessness brief, non-recurring, and rare. Prioritization helps everyone in the system that allows them to make informed decisions based on need and acuity, ensuring that people are connected with the best housing to fit their needs and that limited resources are used as effectively as possible. Another point to make with this is just as a physician wouldn't prescribe the same treatment to patients on a first-come, first-served basis and without regard for their particular injuries or ailments, so for example, stitches won't work for a heart attack like it will for somebody with a deep cut, neither should a community working toward ending homelessness function this way. Rather than going down a list and matching people with whatever assistance may be available, a successful community takes into account a number of factors such as health and length of time homeless in order to serve individuals or families experiencing homelessness based on their unique needs in accordance with research and local priorities. So what we're going to do now is we're actually going to do a exercise on prioritization. So this comes directly from, where is this? Somewhere. From CPD, from Notice CPD 14012. The title is Prioritizing Persons Experiencing Chronic Homelessness and Permanent Supportive Housing and Record-Keeping Requirements for Documenting Chronic Homeless Status. HUD does not keep it brief, do they? Which was released in 2012. We're going to go in depth about prioritization for PSH, rapid rehousing, and transitional housing during the next webinar once our written standards are more complete. But what this notice does is establish an order of priority for dedicated and prioritized PSH beds, which COCs are encouraged to adopt in order to ensure that those persons with the most severe service needs are given first priority, inform the selection process for PSH assistance not dedicated or prioritized for the chronic homeless, to prioritize people who are not yet, but are most at risk for becoming chronically homeless, and provide uniform record-keeping requirements for all recipients. We use this for our PSH written standards. HUD came out with them 2014, and it is the standard. It is what they want us to do PSH, and we heard that loud and clear, and they are in our PSH written standards. However, why I'm showing this to you guys is so that we can practice kind of what prioritization means. So as you'll see here, priority 1 is chronically homeless individuals and families with the longest history of homelessness and the most severe service needs. And for our purposes, this will be determined through the BI SPDAT and the FBI SPDAT, which is why we're mandating you all to use it. Priority 2 is chronically homeless individuals and families with the longest history of homelessness. Priority 3, chronically homeless individuals and families with the most severe service needs as determined, again, by the VI SPDAT and FBI SPDAT. And priority 4 is all other chronically homeless individuals and families. So what we're going to do is I'm going to move into 2 different exercises. The first one, we have client 1 and client 2. So client 1 is a chronically homeless man. On the VI SPDAT, he scored a 17 and he's been homeless for 20 years. Client 2 is a chronically homeless man who also has a VI SPDAT score of 17 and has been homeless for 19 years. So Caitlin is going to launch the poll. I'm going to set up this prioritization again so you guys can all practice this. So 81% of you said it's client 1. You are correct. For those of you that responded that it was client 2, the reason that it is not client 2 is because he has been homeless for 1 year less than client 1. So client 1 falls under priority 1, which is chronically homeless individuals and families with the longest history of homelessness and the most severe service needs. And he won out just by virtue of being homeless a year longer. Ugh, I hate having to say one out, but that's what it is. Okay, the second one is, give me a second. So we have client 1, they're a chronically homeless family. They have their FVI SPDAT score of 11, and then client 2 is another chronically homeless family, and they've been homeless for 3 years. So I'm going to take you back here. Did you open it? Is there a poll? Yeah. Sorry, Caitlin's opening the poll. Oh, yeah, so you'll do the third one, not the second one. I forgot that I was going to pull that. Sorry, guys, hold on a second. This one's trickier. And we're at split decision right now. So it's 50-50 right now. So it's actually client 2. Client 2 follows under priority 2, which is chronically homeless individuals and families with the longest history of homelessness. Client 1 actually would fall under priority 3. So as you can see, this takes a lot of, it's going to take a lot of practicing and working through it and being really patient because there's a lot of criteria that we need to look at, but we will get into that next webinar. I just wanted you all to see or get a taste of what the prioritization will look like. Okay, so now thank you all for that. Thank you, Caitlin, for managing that poll. Okay, so now we're going to get into the Common Assessment Tool. So determining how to prioritize limited resources isn't always straightforward or simple, which is where the Common Assessment Tool, or CAT, you'll see some cats in here because in this PowerPoint because Common Assessment Tool CAT comes into play. A CAT is a standard set of questions used by all agencies and organizations in a housing crisis response system that allows the local team to quickly assess people based on their unique circumstances and needs. Additionally, it helps service providers find the best housing match to fit these needs. CAT data creates the foundation of an informed coordinated entry system, offering a bird's eye view of everyone experiencing homelessness in a community and providing a way to connect each person to the most appropriate housing option. Data collection through a common assessment tool helps communities make informed decisions for referrals to available housing and service resources to ensure that the response is right-sized and that the response is not first come, first serve. If a connection to permanent housing and services is the output of a well-functioning coordinated entry system, then by name common assessment tool data is the critical input. Without it, it's hard to connect people to housing in a strategic or comprehensive or coordinated way. The use of a common time event, but rather an ongoing process. A successful community should use its CAT to constantly update its by name list or its housing priority list in real time. This information can then be used to help track progress towards zero or towards ending homelessness and to develop and refine a community's takedown targets. I also want to make a note that this technique, so this common assessment tool technique, is used in a variety of issue areas such as healthcare, disaster response, and education. So an example could be the STAR test that kids have to take. Common core tests are used to measure student success across the state. And if every test was different in every community, there would be no way to say, in Texas, the average third grader reads at a second grade level. Results would differ from community to community, and planning at the statewide level would be impossible. So why? You'll notice I have a lot of why slides in here. So why? Why are we doing this? So one, it allows everyone in the housing crisis response system to know everyone experiencing homelessness by name. So with the 100,000 Homes campaign, this was the crux of the whole thing. So if you didn't know who you were serving day in and day out, you don't know necessarily what resources they need and how you need to develop resources in order to serve people efficiently. You don't have to collect information several times. This is a big one. I think HUD, when they developed HMIS, really had the intention that we would be doing direct data entry and people would be looking to see where other people have gone before even doing intake with them. And I can say from personal experience being an end user, that does not happen. That did not happen when I did it, and I can't imagine that it happens very frequently. And it's just, it's client friendly to not require them to answer the same question every time they go somewhere for assistance. Ian DeYoung, in his blog post about how the SPDAT meets HUD's requirements for a common assessment tool, talks about the potential re-traumatization of constant question asking of clients. So I think we're asking you to do these things and engage in internal process change and to do a common assessment tool in order to be more cognizant of this. Some data, the third thing, same data points mean everyone in your housing crisis response system are speaking the same language. So if you're not gathering the same information, you can't talk the same language. So that was my point about the STAR testing. So if every community has different assessment tools that they're using, there is no way that from community to community they can have the same discussion about the same person. It also creates a systematic way to consistently update and track important information. So I know I've seen it in evaluating or analyzing coordinated entry data from the pilot communities. We have a lot of clients that travel between Texarkana and Tyler. And essentially what's between the agencies is that they're constantly updating the SPDAT information to make it more accurate. So there have been a lot of instances where I have seen clients get assessed in one community and have a score of 2, who are later assessed in a different community several months later who now have a score of 4. And we are able to know what exactly that person needs to end their housing crisis regardless of what community they're in. And then last, improves planning and optimization or optimizes the allocation of resources. So in regards to the planning, the more data you have, the more concise data that you have, the more common data that you have, the easier it is for you on a system-wide level or a housing crisis response level to make decisions about what you need in your community. So another example from the analysis I've been doing with the coordinated entry data, it is very clear to me that in every community we need more homelessness prevention money. It's so clear, it's like crystal. And I think you guys know that anecdotally, but at least now I have the data to show we don't have it, and this is the result. We have emergency shelters that are over capacity constantly. And it also ultimately it also optimizes the allocation of resources. So because you are able to match someone to the appropriate intervention, you're also able to make sure that you're prioritizing people based off of their vulnerabilities for that intervention. So you're making sure that the people that absolutely need the assistance right now are getting it. Okay, so I'm going to talk a little bit about the VI SPDAT and the FVI SPDAT. So these tools have been around for a while now. They're actually developed out of the VI, or the Vulnerability Index, that was used by the 100,000 Homes campaign, which is actually a tool that was developed by a committee of the United Nations. And I believe for like 2 or 3 years, the 100,000 Homes campaign was just using the VI. And it's essentially what it is it's assessing people for medical vulnerabilities, so more of like the health spectrum. And then Ian DeYoung, you'll hear me talk about him a lot. I've drunk the Kool-Aid. I completely 100% agree with him. He developed the SPDAT assessment tool, which is a case management tool which has a pre-screening component. So that is the component of the SPDAT that we utilize in the VI SPDAT and the FBI SPDAT. And it's looking at a variety of domains. So we're looking at the history of housing and homelessness, people's risks, socialization and daily functions, and wellness. And then for the family VI SPDAT, it includes obviously questions about the family unit. It's a wonderful tool. Gotta be honest, I totally had doubts about it before I used it, and I did an outreach event with the Austin Continuum of Care for an encampment that was getting kicked out because, anyway, terrible things. But so an encampment that was getting kicked out of a neighborhood, and I did an assessment with a client. I hadn't had any training on it. All I had to do was read the questions verbatim. There's an intro. I read that. I read the questions, and we were done in less than 7 minutes. So it's a really concise, wonderful tool. But there are other reasons other than my own personal experience for you to want to do it. So it's a tested tool. So it's been used for the last 6 years at least in communities across the country, across the world even. With the materials that I send out after the webinar, will include a lot of the evidence briefs about the VI SPDAT, so you can see where it is used, how long it's been used, everything. It's evidence informed. So Ian, I believe he looked at like 300 different articles on homelessness, vulnerability, everything you can imagine, and from that he developed the VI SPDAT and the FVI SPDAT. It's also a tool that makes effective recommendations across a variety of housing options. This is actually one of HUD's requirements for a common assessment tool, is that it helps eliminate subjectivity and makes it more objective. And then lastly, it's a reliable tool. Regardless of who does it, it should result similar or exactly the same results. It's a valid tool, it's been tested, and then it also has a predictive value, as I mentioned. So it meets HUD's guidance. I don't really like the document, but it has very limited guidance, and they did focus particularly on reliability, validity, and predicted value, which VI SPDAT has all of those 3 things. So just so you guys can see what prioritization will look like as a result of the VI SPDAT and the FVI SPDAT scores. So Anybody who scores a 0 to 3 on the VI SPDAT, which the VI SPDAT is used for single individuals, we are going to attempt to divert and prevent them from entering the system if at all possible. And the idea is that you would prioritize people based on the higher their score is. So if they have a 3, you may need to provide more financial assistance or other assistance to them than somebody that scores a 0. Somebody that scores a 0, I would imagine 0-1, is an ideal person to do diversion with. Then for folks that score 4 to 7, this is rapid rehousing or transitional housing. So I do want to say on the tool and also on HMIS, when you get to the scoring section, it only says rapid rehousing. And there's a variety of reasons why that's the case, but we have a lot of, we have a lot of transitional housing in the balance of state, not as much as we did before, but we have some. And so we need to provide the clients the option or the choice as to whether they would like rapid rehousing assistance or transitional housing assistance. This is, of course, after checking eligibility against the client prior to that. So the idea is that you'd be prioritizing based, again, off the highest score. So those with a 7 would be prioritized over those with a 6, over those with a 5, over those with a 4. And we were talking about it yesterday. In our rapid rehousing transitional housing written standards, we're going to include something about allowing communities to select their tie-breaking or their other priority populations based off of your data. And we'll talk about that at length next time. And then for those that score an 8, the higher the score, the higher the priority. So it's 8 and above. I believe it goes everywhere. I believe it goes up to 17. So obviously 17 would have priority over a 15, 17 would have priority over a 12, 12 would have priority over an 8. So hopefully you guys get that. And then the FBI SPDAT, same thing. You'll just notice that the scoring for rapid rehousing or transitional housing and for PSH are 1 higher. So it's the exact same. You will do the exact same thing. Okay, so this is the fun part.
We have a question,
Yes.
Cynthia, from Holly Bates. It says, how would a community client fit into the scoring prioritization? Are we going to address that later in the webinar?
Yes. Yeah. Did she hear that?
I don't know.
So, Holly, we will address that in a little bit. But great question. Okay, so next step. So there we go. Okay, so I wanted to very clearly outline our expectation for you guys because this is going to require a lot of work. You're not doing the work alone. We will be doing this work with you. So our expectations is that when a client comes in for assistance, direct data entry is happening. So they're being looked up in the system to see if they already have an assessment. If not, they are getting assessed. If so, they are not getting assessed. And we will set a standard, We will set a standard for the time frame between assessments. So we'll provide that guidance next webinar. The second is you will be assessing everyone who presents at your agency for housing assistance. Everybody. So it's not just people that you think will be good for your COC program. You are assessing everybody. Again, the reason why we're using these tools is because of objectivity. So if you are picking and choosing who gets the assessment, that is subjective. Therefore, you need to assess everyone who presents at your agency for housing assistance with the VI SPDAT or the FVI SPDAT. You need to prioritize individuals for housing according to their VI SPDAT or FVI SPDAT score. We've covered that this whole entire webinar, but that is something that's going to happen. Every person that you place into your COC projects after July 1st need to come directly off the housing priority list. And that's in HMIS, and for DV providers, we will be creating a workaround for you all, and we will set up a training for you at a later date. And then, I mentioned HMIS usage, but HMIS is required for all assessments and all referrals. So you need to be tracking referrals in the system as well. And just again, the deadline is July 1st. So just so you guys know how this is going to, like, these are just examples of how this will look in your community or in your agency. So a client will present for housing assistance, you'll check them in the system, they're not in there yet or they haven't gotten a VI SPDAT, you'll complete the VI SPDAT with them, it'll give you a score. In this instance, the client has got a score of a 7, which is rapid rehousing or transitional. After discussing the different interventions with them, the client has decided that transitional is most appropriate for them based off of a variety of their circumstances. And so you're going to check the client's eligibility for transitional, and voila, they're eligible. So then you're going to check the housing priority list in HMIS. If you're a DV provider, it'll be probably a by name list. And then, oh, look, your client also has the highest score for transitional housing. So then I'm going to look to see if I have an open unit. Oh, I do. So then you're going to process the client intake, and you're going to put the client directly into housing. Sorry, people are slamming doors around here. So then you're going to put the client directly into housing. You will have affected, I mean, I realize this is like a pipe dream, but you will effectively have put somebody into housing in one day. Like, this is the goal. The goal is to get people into housing as soon as they present. I realize there are limited resources, but hopefully as we're reorienting your systems, this will become more frequent than infrequent. Another example, so a client presents for housing assistance. Again, I check them in the system. They don't have a VI SPDAT. I complete the VI SPDAT. They have a score of 7. Client again determines transitional is the best for them. We check the client's eligibility for transitional. They're not eligible. Refer to emergency shelter. Another example, client presents for housing assistance. We check them in the system. They don't have a VI SPDAT, so we complete it with them. Again, they score a 7. We check their eligibility. They're eligible. We check the housing priority list. Unfortunately, the client does not have the highest score, and so we either refer them to emergency shelter, and then DV providers, you'd place them on their on your housing priority list. Yeah, we'll talk about that later. So now homework, because this is not going to happen by us not doing anything. It's not going to happen overnight. We're not I Dream of Genie. We're not just going to snap our fingers and it's going to happen. So prior to the next call on June 1st, agencies with COC funded projects must review internal processes and procedures to allow for direct data entry and assessing people with the VI SPDAT prior to intake to any programs. Obviously also putting them on a priority list. And a huge component of this is reviewing your intake procedures and eligibility criteria. I didn't realize that moved. But review your intake procedures and eligibility criteria in an effort to lower barriers to obtain housing. So it's a lot of, it's going to be a lot of work. It requires, what I've seen through my work with coordinated entry is we were just focusing on the systems level and we didn't focus at each agency that makes up the system. And that's why I feel like coordinated entry has been hard to implement in communities, because if you're not engaging in systems change at an individual agency or project level, it's not going to happen at a system level. Do you have anything to say?
Yeah, I just wanted to say, if you're serving a subpopulation and that is what you've received funding to do through the COC program, that's not changing, right? Those clients still need to meet that criteria. You'll have heard us talk about reviewing your eligibility criteria multiple times and lowering barriers to housing. We're still going to work on that. If you haven't had your project review, we're going to be asking you to send us all of this information for us to review to assist you with doing this. So I know, in Austin and many other places, there is a part of the anxiety around this was we won't be able to serve the clients that we're funded to serve. That is not the case. That's not something we're changing. If you are a permanent supportive housing project and you're not dedicated to the chronically homeless, If we haven't already had a conversation with you about that, we're going to be having that conversation very soon.
And we're setting up meetings about it. So, and I do want to say that you guys are not doing this alone, so we will be setting up meetings with you similar to the project review calls. So we'll be getting all that information from the project review calls on your eligibility criteria and intake criteria. We're going to set up a separate meeting to talk about how to streamline your internal processes and procedures. So that's what we're really focusing on, and a component of that is direct data entry. So excellent point, Mary. So if you don't know what direct data entry is, you're putting in the information, you're putting the information in HMIS with the client sitting right next to you. So it's not, with the client sitting right next to you. So, or right after if you have to, but our expectation is while they are there. And the value of this, guys, is you're not filling out assessment that later needs to go into HMIS. You're not doing like double duty with the data. You're getting it in the system in real time, which is an added benefit for you, but also for everybody else in your system as well, because it's updated, it's timely. It also looks better on the UDQ reports. Like it's a, I don't know, I'm terrible with cliches. Trickle down, snowball, I don't know.
Well, and I think Sophia mentioned this earlier, and I'm the one sitting next to her that was like, or right after. We understand, you know, and I think this is part of this assessment being done prior to your intake being done, right? That there are forms you're going to have to fill out and put in a client file. But there's also an opportunity, and I think this is something we want to work on with everybody that's using HMIS, to gain a lot of information about your clients from the system. So if you have a client in front of you and you're able to look in the system, and we are going to be opening it up even further, and you can see their history and see where they've been, there's a lot of information you can gain. And again, a lot that a client doesn't have to tell you again. You know, so after you've done the assessment, you can look and see, this client's been in and out of 3 emergency shelters and 2 PSH projects. Like, what's happening? What hasn't worked before? A really honest conversation about that. And also, again, not having to have clients retell their story constantly. We know that it's traumatizing. And this also, you know, this is an effort to make sure clients get to the right place the first time. Is it always going to work? No. The majority of the time, yes. So if we can get a client to the appropriate intervention and prevent them from having to run all over town to projects that, 1, they're not eligible for, or 2, there's no way they can sustain housing. You know, this isn't just a benefit to these humans that are living on the streets. It's a benefit to your staff, your agencies, the whole system. The whole country, the whole planet. I mean, now I'm getting really hippy-dippy, but sorry.
Galaxy. No.
We actually have a question that I think would be really well addressed by UK Range from Lisa. It appears that clients who don't meet eligibility criteria will be counted against us regarding to meeting our target percentages. With a larger intake population, it could dilute the target percentages. How will that affect our scores when competing for funding? Could you speak to that?
Can you repeat the question?
Sure.
Sorry.
So, I guess I should probably say it louder for the folks in the back. It appears that clients who don't meet eligibility will be counted against us with regard to meeting our target percentages. With a larger intake population, it could dilute the target percentages. How will that affect our scores when competing for funding? So I think there might be an error here as far as you're not inputting a client into your project who is then not eligible.
Right.
That would honestly affect your target percentages at all.
At all. Yeah, at least it won't affect that at all. You're doing the common assessment tool to prioritize and then accept if they're eligible. So it's not going to impact your target, and it's not going to impact your score.
I had to read that 3 times.
And good question.
Yeah, that was a really good question. Okay, and like I said, with this piece of the homework, we'll be setting up calls and working with you guys and creating flows as to what you currently do now and how it needs to look and what policies and procedures need to change in order for that to happen. The next is watch the trainings about the VI SPDAT and the FVI SPDAT. They're very similar, honestly. I mean, what Ian's going to tell you in one, he's going to tell you in the other. I still highly recommend that you check them both out. And they're good. Ian's entertaining. So it's, to say the least. So yeah. Have staff practice the assessments with each other. So ideally we'll be utilizing that during the HMIS trainings that you'll be scheduling. And I'll include the email address for that in this slide, but also in the email that I send to you guys tomorrow. So you need to schedule a VI SPDAT and FVI SPDAT training with HMIS. You can email them. I've notified them. You can email them at hmis@thn.org, and you will get trained on both the Common Assessment Tool, but also the housing priority list that we have. I do want to say this does not apply to DV providers because you statutorily cannot enter into HMIS. So we will schedule a separate training. It'll be based on your schedule for the workaround for DV providers. And then bonus points, and I'm going to use this, this is not bonus points for the NOFA. I want to be clear. I don't want to pull a HUD. This is not bonus points for the NOFA. I know. So this is just bonus points in our eyes and in our hearts. We will be talking about these two webinars at the next webinar. Lots of webinars in that statement. They are excellent. These two are probably my favorite of the series that the National Alliance to End Homelessness, or NEAH, is doing, and they both very clearly show what we are asking you guys to do and what it takes to do that. So I highly encourage you guys to check them out. The Pierce County one actually profiles a domestic violence provider, and it's wonderful. So I highly encourage you guys to check it out so that you have an idea of what other people across the country are doing. You are not alone in this change. You are not alone in this hard work. People are doing it across the country. And then ultimately I want to say that we all do what we do to end homelessness. So while we understand that there are economic reasons, societal, like family reasons why homelessness may never truly end, we're working towards a system that makes homelessness rare, brief, and non-recurring. That's what we're working towards. This is not us trying to be a pain in your hides. Like, this is us using the research, using the data, using everything that has been shown to work in the development of a system that makes homelessness rare, brief, and non-recurring. And we are here with you guys. We are here to do the work with you guys. If you reach out to us, we will help you. If you don't reach out to us, we can't help you. We depend entirely on you guys. So I want you guys to keep this in mind when you're thinking about all this hard work that you're doing, that this is the end goal. This is what we're working towards, and ultimately it's going to be better for everybody, but in particular our most vulnerable clients. So, last poll. Are you committed to ending homelessness through prioritization? And Caitlin is going to launch it. And if you say no, nothing bad's going to happen. We will call you to talk to you about it, but we're not going to strip you of your funding necessarily. Okay, so 100% of you, so the 67% who voted said that you are committed. So I spent a long time putting together this webinar to be as persuasive as possible as to why this should be done. And like I said earlier, I didn't want to have to rely on the fact that you guys get HUD funding. I think everything else should be a reason why to do this, and I really hope that that's why you clicked yes. And I'm really looking forward to working with you guys more. I think we've been doing really awesome things in the Balance of State since Cameron started, And I just am looking forward to doing more and more to help our clients and to work with you guys and to help you guys and make things a little bit easier on you. So, Q&A. We have a question. Oh, let's see. We have a couple of questions, don't we? Okay.
Real quick, while y'all are typing out your fantastic questions that we can't wait to hear and hope we can answer today, I'm just going to take a minute while I've got all of you on a call. We didn't get everyone registered for this webinar based on the first email I sent out, which also included some really important information from HUD about, and this was good news. This was when we still had good news from HUD before last week, that like regarding project income and match requirements, it also included these 3 webinars and indicated that they were mandatory for you all. I had to resend an email out to several projects yesterday who hadn't responded. So I just want to remind you all, please, please make sure if you receive an email from us, you read it in its entirety and respond to it and are registered for, well, hopefully anything we recommend, but absolutely the mandatory trainings. We are all here working really hard for you all every day. I know it may not feel like that, but I guarantee you we are, and we try not to send things out unless it's absolutely necessary. But please make sure that you read and respond to our emails. It takes time for us to look through a list and see who hasn't responded and send out another email, and we just really appreciate everyone reading them thoroughly. And also, we don't want you to miss out on anything, especially anything that's important for you to continue operating your project or is going to help you to continue doing that. So please read and respond to your emails from us.
So we have 2 questions. Michelle Wormley. And these, so I don't have as much knowledge about COC stuff, well, like the COC competition stuff or what's been happening with the project review calls, so I may divert this question. So one is, our clients are referred from shelters. What type of intake policy procedures sample document do you have available? And the initial, so it's like 2 parts. The initial assessment is conducted prior to referral from our facility. Shall I provide a copy of the intake form? Michelle, we may need to call you.
Yeah.
I think we're going to call you about that one. Okay. Thank you, Cammie. So we don't have any other questions. If you want, you can submit them. You can also raise your hand and we can unmute you. This is your opportunity, guys. If you heard this and you're still like, oh, this sounds terrible, I don't want to do, I mean, like, this is your opportunity.
Take advantage of this opportunity. Ask us. There are no dumb questions. And Michelle, if you're getting referrals from other agencies, that's fine. And a portion of your intake is being done then before the client comes to you, that's fine. But when they come to you, before you put them into your project, you need to conduct this assessment and look at your prioritization list, which again will be different from HMIS, obviously, for those of you that are serving DV populations.
I'm going to give like a minute. Maybe less than a minute. Oh wait. You will provide a copy of prioritization list for TH. Yes, we will do that the next webinar. Yes, we will provide that.
It'll be in the written standards.
And it will also be in the written standards. So we'll probably come up with like a nice one-pager like here. Yeah, we'll make a pretty little chart. Great questions, Michelle. Okay, so maybe people are a little gun shy.
Yeah, I know we said a minute, but really, y'all?
Yeah.
No more questions?
So if you would rather do this in private,
I think, and the thing is, one, unfortunately, and or fortunately for you all, we would love to be in a room with all of you doing this. I hope you all know that.
Yeah.
All of the work that we do, that's not possible. The questions that you have could also really help others on the call. So again, we're going to wrap in like a second. So if you have a question, please ask it.
I also can't tell you how much we all love when you do ask questions. We all get so excited.
That's why cheering usually happens.
Yeah, there's a lot of clapping, a lot of excitement that goes on in this room when y'all ask questions.
So I will send, thank you, Cammie. No questions, y'all did an excellent job, very thorough. Thank you. So yeah, if you guys want to send an email, you can send it to both Cameron and myself. We can field your questions that way. I will be sending this stuff out tomorrow. We're going to send this to Craig to put on YouTube ASAP, and then I'll get that to you as quickly as possible. And like I said, we'll be working with you guys through this. So you're not going through this process without direction or blindfolded. We read as much as we can. We stay up to date on everything so that we can do a great job for you all and with you all. And so we are all in this together. Yes, the slides will be in a PDF format. Maybe I'll provide my notes. I probably will provide my notes. Yeah, good question. Okay, so thanks everybody. I hope you have a really wonderful rest of your week and a great weekend. And we will see you guys on June 1st.